All right, let's jump right in. Today, we're tackling one of the toughest, most high-pressure scenarios you're going to face in your exams, a psychiatric OSCE station with a patient in an acute manic state. The goal here is to give you a solid framework, the right words to use, and a clear strategy so you can walk in there feeling confident and ready for anything. Let's get started. And there it is. With just one sentence, our patient, Mr. Alex, lays it all out. I am the king of the world. This isn't just overconfidence, right? This is a massive clue into his world, and it's the central challenge you're about to walk into. So the big question is, how do you handle this with clinical skill and, just as importantly, professional calm? So here's our game plan for today. We'll start with the OSCE brief itself, what you're told right before you go in. Then we'll get into decoding the key signs of mania. After that, we'll talk about how to structure your assessment, how to actually master the interaction, deal with the paperwork, and finally, we'll run through a performance checklist so you know exactly what the examiners are looking for. Okay, let's do this. Picture it. You've just picked up that piece of paper outside the exam room door. The clock has started. You are officially in the scenario. Okay, so here's your setup. You're the junior doc in a busy ED. Your patient is Mr. Alex, 27 years old, and his family brought him in because of his erratic behavior. Your job is simple, but it's not easy. You need to do a focused mental state assessment to figure out what's really going on and come up with a safe plan. All right, now for the really crucial part, observation and interpretation. A patient in a manic state is like a whirlwind of information coming at you all at once. The real skill is being able to pick out and categorize the key clinical signs from right in the middle of all that chaos. Now listen to this part carefully. He's not just saying he's visiting the hospital. He believes he owns it, that everyone here, including you, is under his control. This isn't just a random comment. It's a textbook signpost for a specific thought disorder, and our job is to see it and name it. And that right there has a name, a grandiose delusion. It's a fixed, false belief about your own power or importance that's completely disconnected from reality. And look, recognizing this isn't just about using fancy jargon. It's fundamental. It's how you start to understand the patient's inner world, which is key to getting the diagnosis right. And this is where we take all that chaotic energy and start organizing it like a clinician. When you break it down, a really clear picture starts to form. His mood, it's euphoric, almost unnaturally elevated. His speech, it's rapid, pressured, and he's jumping from one topic to the next. That's your classic flight of ideas. His thoughts are full of grandiosity, and his behavior is hyperactive and can even become confrontational. See how it all fits together? So, you've collected the clues. Now what? The next step is to translate all of these observations into the formal structure of a psychiatric assessment. This is where you really show the examiner that you know what you're doing. And this is what it looks like when you put it all together in a formal mental state examination summary. His appearance is normal, behavior, hyperactive, speech has that pressure and flight of ideas, his mood is euphoric, thought content is all about those grandiose delusions. And this last one is so important. His insight is poor. He has absolutely no idea that he's unwell. With these findings, your brain should immediately start firing off some possibilities. The most likely diagnosis for sure is a manic episode as part of bipolar I disorder. But a good doctor never stops there. You have to consider the alternatives. Could this be schizoaffective disorder? Or what if it's caused by drugs or medication? These are your top 3 differential diagnoses. And you have to remember, especially in the ED, you are a doctor first. We have to rule out physical causes. Always be on the lookout for red flags. Is his consciousness altered? Are there any signs of intoxication, like his pupil size or vitals? Any neurological deficits? Any sign of a head injury? Or a history of something like a thyroid problem? These things require an immediate medical workup. Okay, we've covered the what to look for. Now let's talk about the how you actually handle yourself in the room. Interacting with a patient in a manic state, especially one who's challenging you, requires a very specific set of skills for communication and, most importantly, for safety. I want you to burn this 4-step framework into your memory. It's simple, but man, does it work. Number 1, respect personal space. Always have a clear exit for yourself. 2, your body language needs to be calm, relaxed posture, neutral face. 3, actively listen. Let him talk, show you're hearing him. And 4, set clear, firm, but respectful limits on behavior. Not on his beliefs, but on his actions. Okay, this one is huge, and it goes against every instinct you might have. You cannot, I repeat, cannot directly challenge his delusion. It is a battle you will not win, and it will only escalate the situation. Instead, what you do is acknowledge the feeling behind what he's saying. Things like, I can see this is very important to you. Then you gently try to refocus. Your goal here is assessment, not to win an argument. So let's get super practical. Here are some lines you can literally memorize and use. These are your redirection tools. They work because you're validating him first, then steering the conversation back on track. A simple phrase like, thank you for sharing that. My main goal right now is to understand how you've been feeling can absolutely work wonders. The interview's done, you're out of the room. But you're not finished, not even close. Now comes the final test, your documentation. You have to write a clear, concise summary that any other doctor can pick up and immediately understand the situation. And the SOAP note is your best friend here. It's clean, it's efficient. Subjective, what the patient says. Objective, your findings from the mental state exam. Assessment, your working diagnosis and what you're ruling out. And plan, the immediate next steps. Psych consult, one-to-one observation for safety, and the tests you need to run. Same goes for your referral. The on-call psych resident is busy. They need the key info fast. Who is he? What are the main findings? Acute mania, grandiosity, poor insight? And what do you need from them? An assessment for admission and a management plan. Short, sharp, and safe. All right, let's wrap this up by looking at it from the examiner's point of view. How are they actually going to grade you? What are the key things they're ticking off on their list? So, before you walk into that exam, run through this list in your head. Did I keep the situation safe and calm? Did I spot the core signs of mania? And this is a big one. Did I avoid getting into an argument about his delusions? Did I assess insight and risk? And did I wrap it all up with an accurate summary and a safe plan? This is your guide to a great performance. So I'll leave you with this one last thought to chew on. This kind of scenario isn't just about spotting signs and making a diagnosis. It's a profoundly human interaction. The real art here is balancing your clinical authority. You have to be in control, with genuine empathy for someone who is clearly suffering. Figuring out that balance, well, that's what being a great doctor is all about.